and Orthopaedic Academy. Our presenter for the evening is Mr. Tahir Khan, who's a consultant orthopaedic surgeon at the Royal National Orthopaedic Hospital in Stanmore and the Young Adult Hip Unit. And we're very grateful that he's going to talk to us this evening about slipped upper femoral epiphysis. Tonight, there is myself, I'm the host, Nikki Evans, and I have Lydia and Hannah from OR UK who are supporting us this evening. So the plan will be to go through the lecture, and then if you have any questions, if you can write them in the chat, then I can monitor them and ask Mr. Khan at the end. We'll also run a Zoom poll quiz, which is completely anonymous. So if you can answer, and then Mr. Khan will go through the questions with you. For this evening, we're a bit short on staff, so we'll probably only do one Viva station, and we'll make it a kind of intermediate case if we could have a volunteer for that, if you're interested. If you miss any part of the lecture, don't worry, we will record the lecture only, and will be available via the oruk.org website over the next few days. The other thing I just want to mention is, so our next mock Viva and clinical exam course is being held on the 28th of January next year, just in time for the exams in February. So if you're interested, please go to the websites and book your places as soon as possible. So I think without any further ado, I will hand you over to Mr. Khan for the lecture, and I'm sure it'll be very interesting for us all. Thank you very much.
Thank you. Let me see if I can share my screen. Right. Can everybody see it?
Yes.
Yeah.
Let me just go into the slideshow mode. Okay, so slipped upper or slipped capital femoral epiphysis, as Americans would call it. It's a hot topic, both from the exam point of view and clinical practice as well. My talk today is hopefully going to help you how to diagnose it. We'll talk a bit about classifications, management, a little bit about complications, and some special scenarios. So in an ideal world, I'll be asking how many of you think this is a slipped upper femoral epiphysis? And you'll be surprised that a lot of people would call this that it's not slip. Because the talk is on slip, I'm sure you'll agree that there is an element of slipped upper femoral epiphysis. So the take-home message really is that the AP X-rays can, in these people, sometimes look very, very normal. So you should always look for another orthogonal view, and in slipped upper femoral epiphysis scenarios, we always say that you should go for a frog lateral view, and if that's not possible, you should do a cross-table lateral view at least. And in this case, the MR scan was not required really to diagnose, but because we had planned to do a subcapital osteotomy, we would do an MR scan to look at the vascularity. So the bottom line is that in these patients, the capital femoral epiphysis, upper femoral epiphysis, stays in the acetabulum, and the femoral neck moves anteriorly and inferiorly. And hence, the deformity, although it looks like the ice cream has fallen off the ice cream cone, it's the deformity of the cone, not the ice cream. Pathologically speaking, there's always a bit of debate that which bit of the epiphysis is where the slip happens. A lot of us would agree that it's the hypertrophic zone of the physis, which is the biggest zone. And funny enough, that's actually where the fractures happen as well. So is it actually a fracture which happens slowly? The jury is still out. Some people would agree that this is a slow kind of a fracture. Others would say it's nothing to do with that, and it's just an endocrinal abnormality which leads to that. And as it happens, because of this endochondral ossification, the remodeling starts very quickly, and hence the deformities form. A little bit about demographics. The incidence is variable, and it depends on a lot of factors. There is a background of endocrinal and systemic disorders like vitamin D deficiency. radiation and chemotherapy has also got association with slipped femoral epiphysis. It's more common in boys by 2.4 to 1, and 5% of the patients would have a family member who had it. So if there is a gene, it's not a dominant gene. In boys, it's slightly later, and in girls, it happens usually slightly younger, usually perimenarchal time in girls, and when the boys start developing secondary sexual characters. About 2/3 to half of the patients are overweight. And the reason for that, I don't know if that's a cause or the effect. Could it be that they were having hip pain and they can't do exercise? Or is it they slipped because they're heavy? It's difficult to prove. But if you can imagine that a lot of these patients are hypothyroid or they have androgenic deficiencies, they probably do put on weight as well, and there's a fat metabolism disorder. They do also have delayed skeletal maturity, and a quarter of these patients are bilateral. Half of those quarter have signs of slipped femoral epiphysis on the opposite side at presentation, and the other half would develop it later on. Majority of the ones who develop it later on would develop it within 2 years of the first slip being diagnosed. We also know the association. We talked briefly about them. So hypothyroidism, panhypopituitarism, which would be presenting as hypothyroidism as well, hypogonadal disorders, renal osteodystrophy, perimenarchal or premenarchal girls, as I said, and mechanical factors. We again briefly talked about obesity, reduced femoral anteversion, and actually femoral acetabular retroversion, which is becoming more popular and a hot topic. If people went to BOA this time, they might have come across it. The physeal plate and perichondrial ring are also abnormal in these patients, and they usually get synovial hyperplasia, and interleukins are raised in these patients. Now, again, that could be cause and effect, but it's difficult to be sure. A lot of these patients present with pain. Now, although you might think that it's such a easy presentation, but the problem is the location of the pain, because a lot of them would have referred pain in the knee and the thigh. And I've certainly seen patients who have had extensive investigations for the knee, including MR scans, and one person I know of had a knee arthroscopy, which was normal when they actually had slip. Typically, the pain is in the groin and the thigh, but not every patient has a groin and thigh pain. They also limp, and when you examine them, their leg is externally rotated. We also know that 30 to 40% of these patients would have an asymptomatic SUFI on the opposite side. So they don't have pain on the opposite side, but when you X-ray it, you can see slipped femoral epiphysis. So how many of them would have had asymptomatic slipped femoral epiphysis before it got symptomatic, and how long did they stay asymptomatic is unknown and difficult to be sure of. So just to highlight that thigh and knee pain in a young person who may be limping is something you must watch for, and you must take an AP and a frog lateral X-ray. There is an element of pre-slip. So that pre-slip is the patients who do not really have many symptoms, but you do an MR scan and that shows slip, or they present with irritable hip because of synovitis, and you do an MR scan and that shows the slip. So it's again, beware that pre-slip, although some people don't believe in it, there are certainly cases we see in clinical practice. And obviously after that is the acute slip. These are the ones who have less than 3 weeks of symptoms, or chronic slip who have more than 3 weeks of symptoms. Great majority, about 75 to 80%, would have acute and chronic. So they had grumbling pain going on for months, and suddenly that pain gets worse, typically after a sporting injury. So this is one such X-ray, and the astute one of you would know that there is something which is not quite right. It may not look like a slip, and we'll try and dissect it a bit further. So one thing which you can do is draw a trichomen line, and that would show that the ossific nucleus is below the line drawn from the superior lip of the, superior border of the femoral neck. Or there is a double shadow So if you see, there is a shadow from the femoral neck, but there's also a shadow from the epiphysis. And inferiorly, there's a lack of overlap. So normally at this end, at lower pole of the metaphysis, there's an overlap between the epiphysis and the metaphysis, and that's deficient. So there are a lot of signs that you can look at. So Klein's or Trithon signs are a blank sign with an overlapping bone, a sham sign with a lack of overlapping of the epiphysis, physial widening, and epiphyseal height. These are the telltale signs you need to look for when you look at an AP pelvis X-ray with somebody who's got pain. And I can't repeat enough times to say that diagonal X-rays are the key. So you need to get either a frog lateral or a Billings view. Ultrasound scan, debatable. Some ultrasonologists can diagnose it with the ultrasound scan, but CT and the MR scan, if in doubt, must be done. And that will confirm your diagnosis. This is what I was talking about, thanks to Pranay Budhe, who's done some work during his fellowship here in Sydney. And he came up and he found out that a lot of these patients have excessive femoral retroversion as well. And that is something which can have an impact on their later outcome, about their impingement, which we'll talk about later on. And also, if they have a retroversion on the contralateral side, then maybe we should fix them in situ before the slip. Right, so the most famous classification that you must be aware of for your exam, and it would be almost a competency question. So if you're not aware of a stable and unstable hip, it'll be difficult to get through to the next stage. So this was a paper by Loader in 1993, General Bone and Joint Surgery, and he classified them into stable and unstable hips. And the stable ones are the ones who can bear weight. The unstables are the ones who cannot bear weight. The important thing, though, is that the stable ones are the ones who usually have a better outcome, and they can be fixed in situ, whereas the unstable ones are the ones who usually have a poor outcome, higher risk of avascular necrosis. Obviously, it's not just the stable and the unstable you need to look for when you're thinking of fixing in situ. We'll have a look at some other parameters as well. And that's the other classification. So you can use the grading system, or you can use Southwick angle. And compared to the opposite side, the mild slip is less than 30% slip, moderate is 30 to 50% slip, and severe is more than 50% slip. So moderate to severe, or grade 2 and 3 slips, are the ones where fixation in situ is a bit tricky. And sometimes the fixation in situ is not even possible because your angle to put the screw in would be so anterior that you run the risk of damaging neurovascular structures or missing the epiphysis. Even if you can do the fixation from such an anterior point of entry, they usually get impingement as well quite early on from the screw head. So mild slips or grade 1 slips, fixation in situ would be a good option, but grade 2 and 3 and moderate and severe slips usually need an osteotomy. So the natural history of these conditions is that these patients typically develop pistol grip deformity or femorovestibular impingement. And if you look at the patients coming in for hip replacement with osteoarthritis, almost half of them would have this deformity. Now, how many of them had a slip and how many of them were born with that deformity is open to debate. But we also know that these patients usually develop early osteoarthritis, and the severity of that is directly related to the severity of the slip. There's a paper in 1996 looking at 155 hips, and they compared the mild and moderate slips, and they came to the conclusion that severity of the slip has certainly a bearing on the speed with which they develop osteoarthritis. So the prognosis obviously depends on degree of slip at presentation and age of the patient at presentation. Now, age is quite important. So the patients who have younger age at slip, they would have capacity to remodel, whereas the older patients typically would not have that capability, and hence they may develop articular cartilage degeneration and impingement sooner. The impingement would then later on lead to labral damage and contralabral dissociation, which would then cause osteoarthritis as well. The second factor which the prognosis depends on is chondrolysis. Now, some of these patients would develop chondrolysis quite early on, and you can see that in untreated hips as well. And hence, a lot of people are not doing arthroscopy at the initial presentation to assess that, and then do the fixation, and depending on how bad the chondrolysis is. Now, avascular necrosis is rare in untreated hips, but can happen. But in the treated hips, the ratio, the incidence is about 10 to 15%, as we'll discuss in a little bit later. So sphere slips treated with bone grafting, they typically have a good outcome in about 80% of the patients. Sphere slips fixed in situ, again, would have good outcome, but their range of movement was typically restricted. So when we're talking about the good outcome, we're talking about the early periods after surgery. In the long term, the sphere slips fixed in situ typically develop arthritis sooner than they would have done otherwise, and they do have femorovestibular impingement. Now, femoral neck remodeling, we think if the slips are up to about 60 degrees, they would remodel, and that's typically ones who are less than 1/3 slips. So if the slip is more than 1/3, which is moderate or severe, the femoral neck remodeling is not as good, and hence they would have long-term consequences. So poor long-term prognosis, again, a bit of repetition, is associated with sphere slips and mal-united slips, the ones where there's a postoperative deformity. And hence it's quite important that we should aim to restore the normal alignment. Now, if you cannot restore normal alignment, then there is a chance of early arthritis. But I cannot say with the hand on heart, or there's no published evidence to prove that if the normal alignment is restored, then it prevents osteoarthritis. The answer to that is still not available. So when you're treating them, your goal is to prevent further slip, to stabilize the slip as it is. So hence fixation in situ. You stimulate early epiphyseal closure. That's your primary aim, so that you don't want it to slip further. But that aim has to be modulated in younger patients, typically the ones presenting in their 6 or 7 years of age because of previous radiation or endocrine abnormalities. Because if you close the epiphyses, they will end up having leg length inequality. The third aim is to avoid complications like chondrolysis and avascular necrosis. And the fourth is to preserve the hip joint function, and if possible, improve that hip joint function by delaying joint degeneration. So one way to do that, and believe it or not, this used to be used many, many years ago, that you can put them in a hip spica, or do a bone peg epiphysedesis, or fix it with a smooth wire. So this is one of my patients actually from Manchester who had osteogenesis imperfecta, and then she developed slip. So now she already had a telescopic rod in there, and we had to fix it with Juvets pins, which are usually typically threaded at the tip and threaded laterally as well, so that you can put a screw on it. She went on to unite in a good position and had a good outcome. I've never put a hip spike on a patient with slipped up femoral epiphysis, but I'm sure people have used it in the past. I've also not used a bone peg epiphysedesis, which is quite an extensive open procedure. In situ fixation remains the gold standard, so to say. A lot of these patients would get a single screw, and there is enough evidence to say that the single screw is as good as 2 or 3 screws. But that screw has to be 6 to 7 millimeters in diameter. We tend to use 6.8 millimeter screws, but you can use a smaller or a bigger screw. It's important that you get biplane fluoroscopy for that. The screw should be perpendicular to the head, and starting position typically is anterior. You need to get in the central part of the head and leave about 5 millimeter margin to avoid chondrolysis. You need to get 3 to 5 threads of the screw in the epiphysis. If you don't, then there's a risk that the slip may progress further. If the patient is younger, then you try and get 6 to 7 threads to avoid any further slip. Smooth pins are typically not good. I have no experience of telescopic screws, but I know people are using it with good outcome in younger patients. in situ screw fixation, it's superior in a lot of people because it's a simpler procedure, as long as you follow the basic principles. So you must avoid the superior anterior quadrant, and you must screen the hip to avoid any penetration of the articular cartilage. Now, if there is a penetration of the articular cartilage, even with the guide wire, then there's a high risk of chondrolysis and avascular necrosis. The open bone epiphysis, which was very popular back in 90s, it gives a very quick physeal closure, and there is a quick return to regular activities. The disadvantage is that it's a bigger procedure, longer operating time, and there is a risk of graft migration into the joint and resorption. As I said, I've never used it, but it was popular many years ago. Now, if the slip is severe, you can try to do a close manipulation, although I would advise you against it, because just by close manipulation using Ledbetter or any other maneuvers, there's a high risk of avascular necrosis, and it would be difficult to justify that. So if you're going to treat or reduce the severe slip, then you should be thinking of osteotomies, and they should be performed at the same time at the time of stabilization. Very rarely you'll do it after epiphyseal closure. But my suggestion to you would be that if you're going to do it at the same time as primary fixation. So the realignment osteotomies are beneficial because they can address your varus and posterior tilt of the epiphysis, proximal femoral epiphysis. It changes and restores the kinematics of the femoral head articulation. It avoids any articular cartilage damage and a labral damage as well, which can be repaired if you're doing arthroscopic surgery. And hopefully it will delay the degeneration later on. So what you want to do, if you're going to do the osteotomy, you want to excise the callus and take out the physeal cartilage. And then you take out the remodeled extra femoral neck, so that you're essentially shortening the femoral neck, but you wouldn't really be shortening it because there was a lot of remodeling going on for the last many weeks and months. Plus, you need to shorten it to take the tension off the posterior or posteromedial periosteum and the blood vessels, which are running in that periosteum, the ascending branch of the medial circumflex femoral artery. So the benefit obviously are that it is an anatomical reduction and reduces the tension on the blood vessels, so reduces Avian. But equally, if you're not careful, it can increase the chances of avascular necrosis and chondrolysis. This was obviously something which was popularized after by Gans, who introduced the surgical dislocation. But the osteotomies themselves have been carried out by Dunn and Fish over the last 50 years ago, which is when they first published it. You can do other osteotomies as well. If you're not comfortable doing an intracapsular subtrochanteric osteotomy, which obviously is the osteotomy at the site of deformity, you can do an intertrochanteric Southwick osteotomy, which is an extracapsular and low risk of avascular necrosis. But it is an osteotomy performed away from the center of rotation of abnormality, and hence you'll be creating a deformity to correct a deformity. There's also a transcervical osteotomy, which has all the disadvantages of subcapital osteotomy, but again, creates a deformity to correct the osteotomy and hence not very, very popular. Sugioka described a transtrochanteric osteotomy, which corrects a severe deformity by rotating the femoral neck. It looks at the deformity directly, and the femoral shortening is not required. You restore the mechanics, but there is a high risk of complications in about half of the patients, and there's a postoperative deformity. So again, not a popular procedure. So when I talk of subcapital osteotomy, this is what we're talking about. So this patient, as you can see, she is quite mature, and her epiphysis is almost completely closed. So if you try and do the osteotomy here, you'll be struggling to remove that osteotomized fragment out. And hence we decided to do the osteotomy, which is more transcervical than subcapital, and corrected her deformity, and she went on to heal quite nicely. More typically speaking, you will be doing an osteotomy where the deformity is. As you can see there, this is where the deformity has been, this is where the osteotomy has been performed. That anterior bit of the trapezoid has been removed, normal alignment restored, and fixed with 2 screws. Now, we talked about 1 and 2 screws before, and in osteotomy patients, you tend to use 2 screws to avoid rotational malalignment or rotational instability. And because the screws are being inserted under direct vision, it's not as onerous as it would have been if you were doing percutaneously. So the osteotomies, as I mentioned, you do a cuneiform or trapezoidal osteotomy. They have a reported risk of 12 to 35% in fish and gun procedures. Fish reported 3.5% osteonecrosis and 11% chondrolysis in his original series. We published in 2006 our own series, and we found the Avian rate is about 12%, chondrolysis 16%, of which half of them improved over time. So 92% of the patients had normal X-rays at a 10-year follow-up. So, so if you want to do in situ fixation for the opposite side, which is the prophylactic pinning of the normal hip, as in this case, you must remember that there's a risk of avascular necrosis, as shown in this patient. So there is, we know that if you do universal contralateral pinning, you'll be treating 50 to 80% of patients unnecessarily who may never have slipped. We know there's about a quarter of the patients who slip. So you can, if you're not going to do a contralateral prophylactic pinning, you must follow these patients up till scallously maturity and pin the opposite side at the first sign of pain and discomfort. Or if the patient has a metabolic disorder or an endocrinal disorder, then the fixation in situ could be justified. Or if you think the patient is not reliable, then you can do in situ fixation. Sorry, prophylactic fixation. So postoperatively, growth plate we know typically closes in about 4 months after screw fixation, in slightly early in bone peg fixation. They can return to sports in 3 months, slightly later in bone peg fixation, and range of movement can be fully recovered in 6 months. So the biggest complication is articular cartilage damage, which is most of the time iatrogenic because of the hardware penetration. The hardware can break, there can be fractures post-hardware removal, progression of the slip, and chondrolysis. So essentially, the reason I'm trying to highlight this is that majority of these complications are iatrogenic and avoidable. So if you stick to your principles of surgery, then the risk of complication is very low with surgery. Reported incidence of avascular necrosis is 15%. It's 1 to 3% in untreated slips, and it also depends on the severity. So if the severe slip, about 20 to 25% of them would have avascular necrosis. It's also worse with manipulation, closed manipulation, and pin placement is a bit of an issue as well. If they get avascular necrosis, they usually present with synovitis and chronic damage to the articular cartilage with the passage of time. Even a small penetration with the guide wire can start it. So chondrolysis, again, a similar pathology. It's probably an ischemic damage from excessive pressure from both articular side and the increased pressure in the femoral neck. Some people think it's autoimmune, and it's more common in females. Incidence reported is about 2 to 25%. Not every one of them have a slipped upper femoral epiphysis, but some people would get this without any injury as well. It's more common in acute slips, especially if you're trying to fix them before 2 to 3 weeks, or if the patients have been undergoing manipulation stop. There is also a risk of realignment surgery, which can lead to chondrolysis and pen penetration. So if you see a patient with chondrolysis, you must always exclude infection. Sometimes they can have a chronic low-grade infection, and that can lead to chondrolysis. If there is osteonecrosis or chondrolysis, you should try and remove the screws, maintain their range of movement, consider realigning the femur, and a procedure to retain the femoral head in the acetabulum, like a shelf osteoplasty, acetabuloplasty, and improve the coverage. If nothing works, then the only option really is orthodesis or a hip replacement. Similar sort of principles apply for chondrolysis, other than the arthroscopic capsular release, which may sometimes work in these patients. About 2/3 of these patients, about 64%, would improve spontaneously without any intervention. Coming to the end of it, so some of these patients would develop impingement after slipped upper femoral epiphysis, especially this patient who had a fixation in situ, and hence you have to treat them 2 to 3 years after. There is a vogue these days that people would treat that at the initial fixation. So do an arthroscopy at the time of fixation and remove the impingement lesion at the same time, which I suppose the jury is still out, as we haven't had enough evidence regarding avascular necrosis and other complications. So I'm going to finish here, unless anybody has any questions.
Thank you. Thank you, Mr. Khan. So I can see a couple of questions in the chat. So I've got who's asked how to measure Southwick angle in bilateral SUFI.
So you can't. So in those bilateral SUFIs, you will measure it and you just document as it is. And hence the Southwick classification is not very commonly used. So you'll say moderate, severe, or mild slip.
Okay, thank you. I hope that answered your question, Mohammed. And then I've got another question from Mohammed, who has written how to differentiate between Avian and chondrolysis.
So Avian typically would have a very circumscribed lesion. I'll see if I can bring some pictures of. In chondrolysis, there is overall loss of joint space. So over here, you can see there is Avian there, whereas over here, there's a global loss of cartilage and joint space. So typically speaking, the chondrolysis would look like rheumatoid arthritis, where the joint space is significantly lost, but the contour of the femoral head is maintained, whereas avascular necrosis would have a very discrete lesion.
Okay, great, thank you. And then Asif Mahmood, I think I know the answer to this question. How do we treat a severe slip in a DGH?
Well, unless people have experience with an osteotomy, you shouldn't. I mean, if you can't access somebody who can do an osteotomy and reduce a slip, then you're going to have to fix it in situ if you can. And then the complication can be dealt with later on. But ideally speaking, they should be fixed with an osteotomy and reduction, open reduction.
Great. Thank you so much. Hope that answered your question, Asif. I can't see any more questions. So shall we move to the polls?
Yeah.
Here we go. Okay, guys. So it's all anonymous. So if you can just make your answers as quickly as possible, and then we can talk through them. Okay, you've got another few seconds to get your answers in, and then we'll talk through the answers.
Okay, I'm sharing the results now.
Thanks, Hannah.
Okay, shall I jump in?
Yeah, are those the answers there, Hannah?
Yes, yes, they are.
Okay. Yep.
Yeah.
All right. Great.
So obviously, I think there's a lot of telltales here. He's a typical age when children would have a slip. He's a male. There is a history of injury. He's apyrexial. So it's unlikely to be infection. So I do not think it's an irritable hip either. He's too old to be an irritable hip. So I wouldn't necessarily do an ultrasound scan. Obviously, if your frog lateral X-ray looks normal, then you can start looking at the other alternatives. It certainly is not a meniscal tear, well, not until proven otherwise. So you do all the other tests and then come to any other investigations. You'll probably do Fulber count ESR anyway to rule out septic arthritis, but the key here is that you need to do a frog lateral X-ray to rule out slip. Because if you misdiagnose slipped upper femoral epiphysis in this patient, he would have a lot of complication. Again, blood cultures and none of the above are not applicable. So well done to majority of the people.
Yeah, if you just sorry, if you scroll down, you should be able to see the next question.
Oh, people have answered all of them? Okay,
yeah,
sorry.
No, sorry.
I'm sorry, I didn't realize that yet. So a patient with unilateral slip always end up having the same on the contralateral side. Well, we did talk about in the talk that only 25% of them, 25% of them would develop on the opposite side. So that's certainly not true. Well, never develop on the other side is wrong as well. Have a higher chance of developing contralateral slip is the correct answer. So they shouldn't be discharged until skeletal maturity, as we discussed. And obviously, it's more common in boys than girls, so it's not true that it's only in females. Okay. And the last one, subcapital osteotomy. It does not carry 100% risk of slipped upper femoral epiphysis. I suspect somebody might have been confused because the original paper by Fish did say that if you do slipped upper femoral epiphysis osteotomy within the first few days, he didn't quantify it, then they have 100% risk of avascular necrosis. So you shouldn't do that in the acute phase, but it does not carry 100% risk. Can be performed in acute phase? No, as I said, you shouldn't perform in the acute phase. If they present in the acute phase, you should admit them on traction for 2 to 3 weeks and make them into a chronic slip before doing the osteotomy. It should be performed 2 to 3 days after the acute phase is over, which is the correct answer. It does not eliminate post-slip deformity, although it reduces the risk of that and affects the outcome of a total hip replacement. That's not correct either, because if you were to do a subcapital osteotomy, that will affect the outcome of total hip replacement, and there's not enough evidence on that. But if you do a subcapital osteotomy, at the time of hip replacement, you'd be excising, even if you leave behind a deformity, because most people would be taking the femoral head out and not do a resurfacing. Even if you want to do a resurfacing, you'd be able to reshape the femoral head. So the correct answer should be performed 2 to 3 weeks after the acute phase. Thank you.
Okay, that's great. Thank you very much, Mr. Khan. So there's a couple of other questions popped up, so I'll quickly ask them and then we'll stop recording. So Mohammed's asked another question. He said, do you use partially or fully threaded screws? And what's the rationale of screw removal?
So I only use partially threaded 16mm screws, and I never take the screws out. The reason you want to use partially threaded is so that you have a smooth barrel in the femoral neck, and the screws are only engaging in the epiphysis. Taking it out, even if, so you only take them out if there's a problem. And even then, taking them out is quite tricky because the bones grow around it. So the screws that we use, they have had 3 models, and the latest one is a reverse cutting one, and they are easier to remove. Otherwise, typically, they're very difficult to remove, these screws.
Thank you.
So only take them out if there's a problem.
Thanks. And the last one is Katie, who's asked, do you routinely use an intraoperative Doppler during osteotomy?
I don't, and I think the reason for that is that the artery is so small that it'll be difficult to look into it. I know people use it. Funny enough, I've done some plastic surgery in my training, and I was never too sure that it would help. To me, it's much more important to be careful with your dissection.
Okay. Thank you.